Bismillahirrahmanirrahim. Today we have talked about venous drainage of leg, of abdomen and thorax, from upper limb. Okay, now starting from the very beginning, we have talked about there are three types of veins present in the leg. One is superficial veins, deep veins, and perforated veins. The examples of superficial veins are great saphenous vein and small saphenous vein. The examples for deep veins of the legs are anterior and posterior tibial veins, are also called anterior and posterior tibial veins or vena commutantes, and popliteal vein and femoral vein. And perforating veins are you can say the connection between deep veins and superficial veins, and they have a valve. Absolutely, they are veins. They prevents the flow of blood from deep veins of leg to the superficial veins of leg. But in rest, normally blood from the superficial vein go towards the deep veins of the leg. But in exercise, we will talk about when we will study some clinical features in exercises. The deep veins of the leg will go to the superficial vein, will cause varicose vein. Okay, starting from the leg. Okay, look at here. The green color we used over here to use the venous drainage from the posterior side or sole of the foot, and red color we used for the blood venous drainage from the dorsum of the foot. Okay, if we talk about dorsum of the foot, there are digital arteries and we have communicating arteries. Digital arteries join together to make communicating arteries. Then we have an arc over here that is called dorsal venous arc, and dorsal venous arc from the medial side will go upward medial to the medial malleolus, will make a vein called great saphenous vein, and that dorsal venous arc from the lateral side going upward, passing through the lateral to the lateral malleolus of the foot will go upward, that will be named as small saphenous vein. If we talk about we talk about the sole of the foot, we already have talked about when we studied the blood supply to the foot. We talked about plantar arc made by the medial plantar artery and lateral plantar artery. And here we have lateral plantar vein and medial plantar vein. They join together and make posterior tibial vein of vena commutantes. These are the deep veins, as we discussed. Posterior, anterior tibial veins, popliteal veins, and femoral veins are deep veins. So this is made by posterior tibial vein is made by lateral plantar vein and medial plantar vein, and they will go upward, and here we have anterior tibial vein. They will join together at the lower border of the popliteus muscle, as we discussed in arterial system. Same opposite direction, you can say. How it is opposite direction? Suppose popliteal artery was dividing into anterior tibial and posterior tibial artery at the level of lower border of the popliteus muscle, and the same like anterior tibial vein, posterior tibial vein join together at the lower border of the popliteus muscle make popliteal vein, and then this popliteal vein it will cross from the opening of the adductor magnus, then this popliteal vein will be named as femoral vein. And something is here, saphenous vein at the level of, this is great saphenous vein is going upward, but at the level of this knee joint, it is going backward, and after, in the beginning of the thigh, again coming to the anterior side. In the posterior aspect of the knee, as great saphenous get, the small saphenous vein will drain into great saphenous vein. Some books are written that popliteal veins also have a branch to the, they join together with saphenous vein, and then they will enter into great saphenous vein. But popliteal vein, terminal branch passing through the adductor magnus opening, it will become that femoral vein. And then this is femoral vein going upward at the 4 centimeter below and later to the pubic tubercle. We have opening called Saphenous opening, an oval shaped hiatus, 1.5 centimeter width and 3 centimeter length. You can see over here, and this is the opening in the fascia lata. In here, femoral vein, this great saphenous vein, after getting the tributaries of accessory vein, will eventually drain into femoral vein. And this femoral vein going upward will get three types of branches, as we know. That is superficial epigastric vein, then superficial external pudendal vein, then superficial circumflex iliac vein, and then the point where femoral vein crosses the inguinal ligament, then this femoral vein will be named as external iliac vein, and we know that two branches like inferior epigastric vein and deep circumflex iliac vein will drain into external iliac vein, and this external iliac vein and internal iliac vein will then join together and make right common iliac vein. The right common iliac vein and left common iliac vein will join together at the level of L1 lumbar vertebra 5. Then they make an inferior vena cava. Plus we have a medial sacral artery, that is a terminal branch of abdominal aorta. We have medial sacral vein that will join maybe to the left or right, but mostly it joins to the left common iliac vein. These are the three branches of the inferior vena cava. Okay, if we talk about just like we talked about abdominal aorta, lateral branches, visceral branches, abdominal branches. Then we have two for the inferior vena cava. We have two ventral visceral branches that are left hepatic vein and right hepatic vein. They join the inferior vena cava from the ventral aspect of the vena cava. Then we have three lateral visceral branches like right suprarenal artery, right ovarian artery, right renal artery. There is an exception over here that all the visceral branches like suprarenal, renal and gonadal arteries, their respective veins like suprarenal vein, renal veins and gonadal veins will enter into the inferior vena cava from the lateral aspect, but there is an exception that left suprarenal vein and left gonadal vein will enter into left renal vein, then they will enter into the inferior vena cava. And length of the left renal vein is 7.5 centimeter and length of the right renal vein is 2.5 centimeter. And okay, there are 5 lateral abdominal branches. One is inferior phrenic vein and 4 are lumbar veins. Then we have 3 originating branches: right common iliac vein, left common iliac vein and median sacral vein. So these are the few branches or tributaries, you can say that, for inferior vena cava. Okay, now few clinical features over here like femoral vein. So this is femoral veins going upward, and here at the lateral side of the femoral vein we have femoral artery over here, and we can feel the pulse of the femoral artery at the mid-inguinal ligament. We have talked about this in the previous class. And femoral vein, that if we need a quick emergency, you can say infusion, you should go for that femoral vein. How? Number one, you have to do anesthetic drugs. Then number second, you have to insert a needle. First of all, you have to palpate the femoral artery. Then you have to insert the needle just medial to the femoral artery, 2 finger breadth below to the inguinal ligament. As we know, okay, so this is the inguinal ligament, femoral artery, and we will feel the pulse of the femoral artery. Then we will, after the anesthesia, local anesthesia of course, we will insert a needle 2 finger breadth below the inguinal ligament, medial to the femoral artery over here. We will insert our needle for life-saving drugs to save the patient's life. Then another clinical feature regarding great Saphenous vein, it is absolutely important. We should remember it when we need an emergency blood transfusion. And it's also helpful for bypass surgery, like coronary bypass surgery. If there is atherosclerosis or brachial arteries are obstructed or femoral arteries are obstructed, then we should use this great Saphenous vein. How? First of all, again we have to do anesthesia first, of course, local anesthesia. Then we have to incise, cut the anterior and superior part of the ankle, a transverse incision. Anterior and superior at the ankle joint we have to do incision which is transverse, you can see over here. Anterior ankle and superior to the ankle we should do almost 2 centimeter incision, and most importantly the Saphenous nerve is present anterior side of the Saphenous vein. So make sure you should not injure that nerve while taking the graft. Okay, then now breast we have talked about that breast have 5 kinds of blood vessels which supplying the blood supply to the heart, especially the anterior part of the breast. Same, the corresponding veins, suppose from the subclavian vein, perforating veins, branches of inferior internal thoracic vein, then superior intercostal vein, and from the axillary nerve, axillary vein, we have highest thoracic vein, pectoral vein, branch of thoracoacromial vein, and last lateral thoracic vein. So that is the blood drainage from the breast. Okay, if we talk about the portal vein, there is no fun in telling that superior vena cava will, superior mesenteric vein will drain the blood at the same points, same locations from where the superior mesenteric artery gives that blood. Okay, suppose from the transverse 2/3 of the transverse colon, from the appendix, cecum, ascending colon, transverse colon 2/3, there is superior mesenteric artery, and inferior mesenteric artery distal 1/3, then descending colon, sigmoid, and superior part of the rectum called superior rectal vein. It is inferior mesenteric vein. Then splenic vein, there is no fun in telling left short gastric vein, then left epiploic veins, gastroepiploic veins, and then splenic vein will join together. Splenic vein plus inferior mesenteric vein, they join together, and this branch and this superior mesenteric branch will join together at the neck of the pancreas. They make a common vein that is called portal vein. The size of the portal vein is 2 inches or 5 centimeter long, and left gastric vein and right gastric vein and gastroduodenal vein, or you can say right gastroepiploic vein, or interior or superior, anterior and posterior duodenopancreatic vein, superior pancreatic duodenal vein will drain directly into the portal vein, and cystic vein. They have a direct drainage into the portal vein. And then at the level of porta hepatis, this portal vein divides into 2 terminal branches, and they will make a hepatic sinusoids over here. That's why we name it portal vein, as we discussed in earlier classes. That portal system or portal, we should name that vein or artery which have pre and post capillary network. Just remember, we discussed about hypophyseal, hypothalamic hypophyseal portal system, in which we have primary capillaries and secondary capillaries. Look at here, we have primary capillaries over here, like superior mesenteric artery will supplying the blood to the intestine. Then we have capillaries, that is called primary capillaries. Then superior mesenteric vein, and superior mesenteric vein after this junction will make a portal vein. And again we have a hepatic sinusoidal capillary network. So this is primary capillary network over here, secondary capillary network over here. So that's it named as portal vein. And after the sinusoid, we have left hepatic vein and right hepatic vein that will drain into inferior vena cava, and this is the first porto-systemic anastomosis we will discuss at the end of this lecture. Okay, and this clinical feature over here, like right lobe of the liver will get dominantly blood from the intestines, dominantly, and the left lobe plus caudate lobes, they get the more dominantly blood from the stomach and spleen. So if there is any secondary malignant tumor, depends upon this. Okay, suppose the secondary tumor deposition in the liver depend upon either is the intestines or from the stomach or spleen. If there is a tumor in the primary tumor in the intestine, then secondary malignant deposition will be at the right lobe of the liver. If the primary malignant tumor is present in the stomach or the spleen, then the secondary malignant tumor deposition will be at the left lobe of the liver. So okay, after that, okay, we discuss about this mnemonic vein. It is for, veins are the superficial, V for veins, arteries are the deeper, and then nerves are the deepest parts. So the veins that are visible, these vessels are veins. Below the veins we have arteries, and below the arteries we have nerves. Okay, now we will discuss about the blood supply from upper limb. Okay, this green color we are using from the dorsum of the hand. You can see these are digital arteries, then metacarpal arteries. Then we have a plexus over here that is called dorsal venous plexus. And this dorsal venous plexus from the medial side going upward, okay, from the lateral side going upward, passing through the anatomical snuff box, will make a vein called cephalic vein. And this dorsal venous plexus from the medial side going upward, this is on the posterior aspect, right? It will make a basilic vein. You can say this is the digital veins, and then we have metacarpal vein, dorsal venous plexus. From here, from the lateral aspect passing through this anatomical snuff box, this will make a cephalic vein. And from the lateral side, from the medial side, from here, it will make a basilic vein. And this is which vein? Anterior median vein of forearm or antebrachium going upward. And it is a branch with the basilic vein that is called median basilic vein, lateral cephalic vein, and this median cubital vein. Okay, again. and this is the anterior side. This red color for the anterior side, and this green color for the posterior aspect, or you can say this is the dorsal aspect, and this one is the anterior aspect or ventral aspect. So from the ventral, okay, I can explain over here for you. Suppose this is the dorsum of the hand. Here we have digital arteries. Digital arteries, if you can zoom in, digital arteries. Then digital arteries going upward will make there will be a metacarpal arteries, and they will make a plexus over here that is called dorsal venous plexus. And from the lateral side, from this plexus, from the half of this plexus will going this side, passing through this. See, this is the anatomical snuff box. Passing through the anatomical snuff box, the name of this vein is cephalic vein, and half of this from the medial side going upward, this is the dorsum, and now this is the posterior side of the arm, and now this will be anterior side of the arm, and that is called basilic vein. This one is basilic vein, B for towards the body, and this is cephalic vein, and going upward and upward. Another, we have a vein over here which gets the superficial blood drainage. You can see superficial blood from the wrist, from the hand going upward, and this is called anterior median vein of antebrachium or forearm going upward. And there is a connection with the cephalic vein. That vein should be named as median cephalic vein. Connection with the basilic vein, that vein should be named as median basilic vein. And at the level of here, this cephalic vein will terminal branch of this anterior median vein of forearm is basilic vein over here, and it will go upward. At this level, there is a vein called median cubital vein where we have a easy infusion. Then going upward, okay, we talk about over here. Going upward, this basilic vein will go upward, passing through the medial side of the bicep muscle, and cephalic vein will go upward toward the lateral side of the bicep muscle. Look at here, you can see this is the basilic vein, this is the cephalic vein, and this is the anterior median vein for forearm or antebrachium. Okay, then there is a branch with the basilic vein called median basilic vein, branch with the cephalic vein called lateral cephalic vein. Okay, then we have later some books are looking median cephalic vein. Okay, then there is a connection between basilic and cephalic. This vein is called median cubital vein, and this basilic vein will go upward, passing through the medial aspect of the bicep muscle at the level of lower border of the teres major muscle. It will get other tributaries called vena comittantes, that is the deep veins. What is vena comittantes? I already explained. Vena comittantes are the deep veins corresponding to the large veins, or you can say these are the vena comittantes of brachial arteries. The blood, the area supplied by the brachial artery, and the venous drainage from the same area will be drained by vena comittantes of the brachial arteries. So at the lower border of the teres major muscle, this basilic vein plus vena comittantes will make a vein called axillary vein, and this after the this axillary vein will go upward, and this cephalic vein that is going lateral to the biceps muscle going upward, passing through two muscles called pectoralis muscle and deltoid muscle. Between the deltopectoral groove, passing through a triangle called through a clavipectoral triangle, and a fossa called infraclavicular fossa will drain into axillary vein. And now after crossing the first rib, as we discussed in earlier classes, after the first rib, that vein will be subclavian vein. If it is right side, right subclavian vein. And there is no fun in telling. Right subclavian vein will joined by external jugular vein, vertebral vein, internal jugular vein. It will called right brachiocephalic vein. Length of the right brachiocephalic vein is 3 cm. Length of the left brachiocephalic vein is 6 cm. And these veins will join together and make a spirit vena cava. And now we have another, spirit vena cava is not only by right and left brachiocephalic vein, but also with the azygous vein. This is the azygous vein. Azygous vein is made by combination of right ascending lumbar veins and right subcostal veins. Both veins are joined together to make azygous vein. Other tributaries of the azygous veins are 8 lower intercostal veins, right superior intercostal veins, and right mediastinal veins, plus superior hemiazygous vein and inferior hemiazygous vein. Inferior hemiazygous vein is made by left ascending lumbar vein and left subcostal vein, and they make which vein? Inferior hemiazygous vein. Another two tributaries are left mediastinal vein and left lower intercostal veins. And superior hemiazygous vein joins the azygous vein almost at the level of T7, and they drain blood from the 4th to 8th intercostal space. And this azygous vein, after the combination of these veins and these veins, will drain into posterior part of the superior vena cava at the level of T4 or second costal rib, and that superior vena cava, it will enter into the right atrium at the level of 3rd costal cartilage, or you can say T5, and there is no fun in telling right atrium will drain into, blood will go to the right ventricle. Okay, now we will talk about some clinical features. Porto-systemic anastomosis. Anastomosis are a join or a milap between portal system and systemic system. First one is direct connection between the two hepatic veins and inferior vena cava. Come here, left hepatic vein and right hepatic vein, that was the portal system, joined with the inferior vena cava. This is the first direct porto-systemic anastomosis. Then second one is lower esophagus. You can see the lower esophagus, the middle part, middle third of the esophagus drained by azygous vein, that will eventually draining into the superior vena cava, systemic circulation. And this lower third part of the esophagus drain into left gastric vein, drain directly into the portal vein, portal system. So second anastomosis between systemic and portal is at the level of lower esophagus. Then third one is midway down to the anal canal. You can see the superior rectal vein supplying the superior rectus, and middle rectus is a branch of internal iliac. Middle rectal artery is a branch of internal iliac artery. Now we are talking about venous drainage. So superior rectal vein is a branch of inferior mesenteric vein, which are eventually going to the making the portal vein, portal system. And middle rectal vein is a branch of internal iliac vein that will drain into common iliac vein. And then the lower rectal vein or inferior rectal vein is a branch of pudendal vein. It will drain into pudendal vein, and that pudendal vein drain into internal iliac vein, and internal iliac vein eventually drain into common iliac vein. So the superior rectal vein also give blood to the take blood from the superior part of the anal canal, and the lower parts of the rectal veins, they get drained blood from the lower aspect of the anal canal. So midway in the anal canal, we have anastomosis, porto-systemic anastomosis, due to the superior rectal and inferior rectal different venous drainage system. Then fourth one is paraumbilical vein. In paraumbilical vein, there is anterior superficial veins of abdomen will drain into the right part of the portal system, passing through the falciform ligament and accompanying the ligamentum teres. You can say anterior superficial abdominal vein draining into the, passing through the falciform ligament of the liver, of course, then accompanying the teres ligament, and then drain at the left portal vein over here. You can see this is the fourth porto-systemic anastomosis. And then last but not the least, there is an anastomosis between the ascending colon, descending colon, duodenum, liver and pancreas with the renal, lumbar and phrenic veins. This is the fifth and last porto-systemic anastomosis. Okay, then we have other two features called varicose vein and vein thrombosis or DVT. Varicose veins, these are the superficial veins, enlarged and tortuous. There are different pathologies. First one is if there is increased abdominal pressure, maybe in pregnancy or abdominal tumor, or maybe hereditary, the walls of the veins are weak, or maybe the valve of the veins are incompetent, or maybe the thrombophlebitis of the veins, deep veins. Actually, the varicose vein is not a life-threatening condition, but we have to treat it to remove the pain and discomfort. Okay. What about valve incompetence? We have talked about over here. So this is great Cephalin vein. For example, this is one vein, and veins have a valves which prevents the two-way flow, which are helpful for the one-way flow from periphery towards the heart. And if there is a valve system of the peripheral perforating veins are damaged, then what will happen? Blood from the deep veins will enter into the superficial veins that were, as we talked about in the very beginning, perforating arteries. They prevent the blood flow from the deep veins to the superficial veins, but in rest blood go from the superficial vein to the deep veins. But in exercise or in that pathologies, the blood will go towards from the deep vein to the superficial vein, from the deep vein to the superficial vein. Why? Because the valves are incompetent, or the valves of the veins are weak, or there is increased intra-abdominal pressure due to pregnancy or a tumor, or maybe thrombophlebitis of the deep veins. The varicose superficial veins will be enlarged and tortuous, maybe of the leg, maybe of the thigh, or maybe of the pelvic area. And treatment: surgical ligation of the tributaries of the superficial or great saphenous vein. And if there is a valves are incompetent, the perforating vein, simply ligate the perforating veins. And then we have a DVT, deep vein thrombosis. Pathologies are different. First one is if there is an immobilization for several hours, especially in a long distance flights, and maybe due to trauma, or maybe due to any infection, due to inflammation or injury. What will happen? At the cusps of the valve, we discussed, suppose look at here. If this is the vein, this is the valvular system. In the cusps of the vein, there will be a clot formation. Clot formation of this clot by RBCs, by platelets, by fibrin and thrombin, and the if the this clot made by RBCs or platelets or thrombin or fibrin, when it will be sloughed out from this part, it will go upward towards the heart, and passing through the heart will go to the lungs, and they will cause a pulmonary embolism. Okay, we will talk about there is a valvular cusps. The clot made by RBCs, platelets, fibrin, thrombin go towards the heart after the sloughing off from the जब वो उधर से उतरता है clot cusp से, तो the blood will go towards the lungs, and there will be a pulmonary embolism. Clinical features are shortness of breath, sweating, increased cardiac beat, then fainting, then chest pain, then troubled breathing, coughing, and will lead to the cardiac arrest. And we talk about the treatment of this DVT. This is stretching of the legs every hour to improve the venous circulation, and we give anticoagulants, or we call blood thinners, especially the heparin or warfarin, loprins. These heparin and warfarin anticoagulants will not remove the clot, but they will prevent the increase in the size of the clot. So that is the treatment of deep vein thrombosis, and we have discussed about these all things. Anastomosis. Anything else?